mode. Unmuted.
Good morning, everyone. My name is Stephanie Romano, and I'm the Education Coordinator with the Base Hospital Program. Welcome to a webinar presentation on pediatric respiratory distress. Today presenting for us, we have Dr. Matt Davis, our local medical director with the Base Hospital Program and also the medical director of education. We also have Dr. Sheena Belisle, PGY5, Pediatric Emergency Medicine Fellow. If this is the first time you've attended one of our webinars, you're going to see a PowerPoint presentation and hear us talk about the presentation. We will also be able to take questions. So you'll see in your control bar, your task bar, a chat box or a question box. And you can actually type questions in there to us throughout the presentation. If it's a question that we feel the entire audience would benefit from answering, from the answer, we will actually take that to the presenters and they will ask the question and provide an answer live. Otherwise, I can chat with you in the background about any other questions. This is also an interactive webinar, so you're going to get some poll questions. There are 4 of them, so make sure you're close to your screen and can answer those as they pop up. If there's a couple of you watching a webinar together, please do let us know through the chat box, and then we'll record that both of you are attending for CME points. And so, without further ado, I will end the intro and I will pass it off to both Matt and Sheena. Sounds like we might be having a little bit of technical difficulty, so give our presenters just a minute and we will figure this out for you guys. While I do have your attention, if I could get you guys to send me through the chat box how you heard about the presentation and also why you're joining us. So we're interested to see why people are joining our CME. So if you could send me that just in the background, that would be greatly appreciated.
Thanks, Steph, for that introduction.
Do we have Matt and Sheena yet?
Are you able to hear us?
Also, for those of you listening now, do send me a chat and let me know how the quality of the audio is.
Yeah. I heard you say, can you hear us?
Okay.
Yeah, so that's working. Okay.
All right, so apparently everyone can hear us. So if there's any other technical problems, let Steph know here. Matt Davis, I'm here with Sheena, one of our Pediatric Emergency Medicine Fellows in London. She's going to share today some pearls surrounding pediatric respiratory distress, and we'll be able to share some wisdom into both the pre-hospital but as well as into the emergency department world for these patients. So without further ado, here's Sheena.
Good afternoon, everyone. I'm really happy to be here today to speak to you about pediatric respiratory distress. This is going to be a case-based presentation, so I've got 7 cases to speak to you about today. So feel free to ask any questions at any point in time, and I'll do my best to answer them between Matt and myself. What I'd like to do is go over a differential diagnosis for each of these cases, and then I want to highlight key points on both history and physical exam that should lead you to a particular diagnosis. And then I also want to review, as Matt said, both management pre-hospital as well as in hospital so that you have an idea of what we do with the child after you've dropped them off to us in the emergency department. Okay, so this is some American epidemiology. So respiratory complaints comprise about 10% of all pediatric pre-hospital calls. Unfortunately, I don't have any Canadian data for this, but I imagine it's probably similar. So now we're going to go to our first poll question.
Right off the bat, get you engaged here.
You're in presenter mode, I can't.
All right, so some technical difficulties with the poll questions here. So what we'll do is I'll just kind of read them to you, and you can think about them at home here and what your answer would be. So the first question that we have for you is tachypnea in an infant is considered a respiratory rate greater than 40, a respiratory rate greater than 50, a respiratory rate greater than 60, or a respiratory rate greater than 70. And based on the ALS PCS, we define an infant as and so the correct answer for that would be a respiratory rate greater than 60. So infants breathe quite quickly compared to their adult counterparts.
They definitely do. And so it's just really important to have an idea about what defines tachypnea in pediatrics, because obviously it's very different than in adults. And so that leads us to our next slide here, where we will define tachypnea. So the definition of respiratory distress is characterized by both tachypnea as well as increased work of breathing. And in terms of the definition of tachypnea itself, so these are just some rough guidelines to keep in mind. So infant greater than 60, a toddler greater than 40, a preschooler greater than 34, school-age child greater than 30, or an adolescent greater than 18. So you have to just have some numbers in your head. These are, again, broad definitions of tachypnea. They get more specific depending on the different sources that you're looking at. But if you just have an idea of about how quickly the child should be breathing for their age, it will really help you to determine how severe their respiratory distress is.
And Sheena, there's a great little table in the ALS PCS regarding the respiratory rates for pediatric patients. So those are, again, as you said, you read different things in different places, and sometimes it's just coming to consensus with certain numbers. So, you know, basically the numbers that you read across resources tend to be relatively the same. So, you know, for our paramedics out there, you can definitely take a look at the table in the ALS PCS.
Okay, that's great. Thanks, Matt. So in terms of increased work of breathing, this is what you're seeing in the child, but also what you're hearing in the child. So you may observe that they've got some nasal flaring, that they're using some accessory muscles, that they're having some retractions, whether that's subcostal or intercostal retractions, or if they're having some supraclavicular retraction or tracheal tugging. In the smaller children, you may also see some head bobbing. You may hear some different noises, so that may be anything from grunting to stridor to wheezing. I'll take a moment now just to tell you what grunting actually is. So what it is a noise that you will often hear in, again, the younger population, so in the babies. And what they're trying to do is they're trying to keep their airways open. So what they're doing is something that we refer to as auto-peeping. So they're exhaling against a closed glottis to try and keep their airways open. So that is something that's very characteristic of pretty severe respiratory distress. And then we'll go over what's the difference between stridor and wheeze is later on in the presentation. Okay, so then it's also very important to know the differences both anatomically as well as physiologically between the pediatric airway and the adult airway. So infants, in fact, are obligate nasal breathers until they're about 4 months of age. So the important part to know about this is that even just some nasal congestion in a small baby can cause quite severe respiratory distress. So sometimes it is just a matter of clearing out their nasal passage to ease their work of breathing. The larynx in a child is much higher, so it's somewhere between C3 and C4 versus C6 in an adult. It is narrowest at the cricoid, and it's much softer. So the importance of knowing this is that it can be much more difficult to intubate a child, because just because you're able to pass the tube through the cords, it doesn't mean that you're going to be able to completely pass the tube, because it is narrower, more inferior to the cords. So just an important piece to know. The trachea is about 1/3 the adult diameter at birth, and it's much shorter. The lungs have a lower functional residual capacity. So this means that their reserve is smaller, so they've got limited protection when their ventilation is interrupted, and their oxygen saturations will decrease more quickly. Their alveoli are elastic, and they're less well developed, and so they are susceptible to collapse more easily. The respiratory control center is immature, and this is really speaking to the infant population. So they're very sensitive that when they're unwell at all, if they've been given any medications, if they've got any metabolic derangements, particularly if they've got any hypoglycemia, that can really set off or can really disrupt their respiratory control center, and so that would predispose them to things like apnea. It can be very difficult to differentiate apnea versus normal periodic breathing of infancy, and so that's something that just takes a fair bit of experience and practice. But what I would caution you to watch for would be long pauses in breathing in an infant are abnormal. So apnea is actually defined as a pause in breathing of 20 seconds or longer, which is a very long time. But in infants, you shouldn't be seeing any changes in their level of consciousness. You shouldn't be seeing any changes in their tone or in their color. So if you're seeing any of those in association with pauses in breathing, it's most likely to be apnea and not just to be their normal periodic breathing.
So basically, a pause in breathing associated with some other finding or clinical suspicion, or a patient or a baby who's unwell, then that would be more concerning.
Yes, yeah, definitely. Thanks,
Okay.
Matt. So if you are seeing an infant that's experiencing apnea, that's a sign that they've got impending respiratory failure, and so they would be an infant that needs to get to definitive care very quickly. Lastly, their chest wall is much more compliant, and I'm sure most of you have observed this in infants that you've seen in respiratory distress. It seems as though their entire chest is collapsing, and so that would definitely be a sign of severe respiratory distress. The last point to make about the differences in pediatric anatomy and physiology would be that by the time the child is about 8 or 9 years of age, the airway is pretty similar to that of an adult, aside from just continuing to be a bit smaller, so both in terms of diameter as well as in terms of length.
So at the end of the day, they're just not small adults?
That's true. No,
all right.
They're not. Okay, so the next slide here, this is the pediatric assessment triangle, and I just wanted to bring this to your attention because it's actually from Apple, so APLS, and I find it's a really great tool to use. It's sort of your end-of-the-bed assessment where you're looking at the appearance, the work of breathing, and the circulation to the skin in the child. So when you're looking at appearance, you're thinking about things like tone. So this would be like how vigorously the child is moving, or are they just limp and flaccid in their parents' arms? How interactive are they? So does the child appear alert? Are they reaching for objects? Do they seem to be interested in their surrounding? Are they consolable? Can the parent comfort them? Are they looking around? Do they make eye contact with you? It would be unusual for a child that's a few months old, 4, 5, 6 months old, to not notice when somebody else walks in the room. In terms of their speech and crying, do they have a nice loud cry, or does it sound weak, muffled, hoarse? Is the child able to speak in full sentences, or do they seem to have difficulty getting words out? Moving on to the work of breathing, so that's what we discussed in the previous slide. And then looking at their circulation, so do they look really pale? Are they mottled? Do they appear cyanosed? And here I just put up a picture of a very mottled leg, because there's often some confusion about what mottling in infants is. And so it's this really lacy appearance that tells us that they've got some circulatory compromise. All right, so we're just moving on to our first case. So I hope that this works. This is a 10-month-old female who's home you're phoned to at 1500. You're told that there's a history of cough for the last few hours, and now the mother's concerned because the child's started to breathe very quickly, and the breathing has also become quite noisy. So I've got a video here, and I'm hoping it's going to work. I can always play it off here. So we're having some technical, oh wait, maybe it's coming up. Turn that.
Just try playing it off.
Yeah.
We'll try playing off here. We'll see what the quality is. It's not so much the video itself, but the sound that the child's making here. if we don't get it, I'm going to have to reenact it. And we want to see my acting skills, so.
Yeah, it doesn't want me to come up. That's weird. It's highlighted.
The anticipation is building.
I'll just give it one more shot here. It was working fine at home. Of course.
All right, well, sorry about that technical glitch there.
Yeah.
So in this video, basically with inspiration, you're hearing the infant make a kind of high-pitched noise, and then expiration, you're not hearing anything with it. So it's a very high-pitched inspiratory noise that we're hearing on this video. And we'll try to maybe use another route of getting that information out to maybe a tip of the week. We can put that video up and let you hear what that sounds like.
Okay, so moving on then to your pediatric assessment triangle. So in terms of the appearance, you see that the infant is sitting up in the mother's arms. He makes eye contact with you and he cries as you get closer. He does appear to have some increased work of breathing. He's got some subcostal and intercostal indrawing. He's got some nasal flaring. And he's got that high-pitched inspiratory noise. In terms of his circulation, he appears normal. There's no cyanosis or mottling, and your general impression of this infant is that there is something abnormal going on. You go on to assess your ABCs. So the airway you think is patent, but with possible obstruction, as evident by this high-pitched inspiratory noise. The child is breathing at a rate of about 50, has good air entry bilaterally, oxygen saturation is good at 99% on room air, and in terms of the C and the D, both are normal and you're not concerned about those. So I want you to think about what you think might be going on in this child. So you should be coming up with a bit of a differential diagnosis in your head for the child that's got this high-pitched inspiratory noise. So when you think about a high-pitched inspiratory noise, you should be thinking about stridor. Okay, so stridor is an upper airway, or what it indicates is that there is an upper airway obstruction. Okay, so if you were to put your stethoscope over the child's neck, that's what you would hear, a very high-pitched inspiratory noise. If you put your stethoscope down lower and you're listening over the lung field, you may hear a transmitted airway sound, but it should be much louder over the neck than it would be down in the lower airways, and that's what really should tip you off to the fact that this is stridor and not wheeze. So.
And I've found a little sound clip here that we can share with you here for this stridor, and again, kind of differentiating this from a wheeze. And this is what stridor would sound like.
That's great. Thank you, Matt. Okay, so moving on then. The 3-year-old that's present then has a confession to make, and he says that he was sharing his grapes with his younger brother earlier around lunchtime, and the mother states that this child had a coughing spell around lunch and that has been coughing ever since. So now with this piece of information, it should be clearer to you what could potentially be going on with this child. So what is the most likely diagnosis at this point in time? What are other things that you would be considering for stridor? And that's sort of what I was alluding to earlier, when you don't really have a full history, but you know that the child has stridor. What things should you be thinking about? So really anything causing an upper airway obstruction causes stridor.
So what are some of those other things there, Sheena, that you may consider as upper airway obstructions or causing stridor, just so that we don't, as soon as we hear stridor, we don't automatically think, oh, this is croup, this is croup. What are some of the other things that maybe less common, but could definitely cause stridor?
Yeah, so definitely. So as you mentioned, croup is one of the more common things. Foreign body is definitely one of the other things that we would be thinking about. Other more rare things would be like infectious causes, like an epiglottitis or a bacterial tracheitis. those could be present in children of any age, but usually younger children, and those are very, very rare diagnoses that we don't see frequently at all anymore because of immunization. Other things would be like a peritonsillar abscess, and that would be in an older child. Normally we see those more in your teenage population. Other things you should be thinking about, allergic reactions, which could be a child of any age, a mediastinal mass, so something that's compressing the upper airway. Also, like very rare things like progressive upper airway anatomic abnormalities like a hemangioma or something that's like growing that's causing the upper airway to become smaller. So the point is that the differential diagnosis for stridor is very, very broad, and that you need to keep an open mind about what could be causing the stridor, and that it isn't always just croup.
And I think a lot of that would be gained just through the history alone.
Yeah, exactly. So history is very, very important.
So we're just up for our next poll question now, and we're just going to launch that.
So this poll question is actually asking you what your management is for a child less than 1 year of age who is choking. So we'll give you about 10 seconds to get your answers in, and then we'll show you what the results are. Beautiful. So we're going to close that and share the results. So you've got 73% of you saying if there's no air movement, provide 5 back blows and 5 chest thrusts.
And so that would be the correct answer, that if the child does not appear to be moving any air, that's what you should be doing. If the child is, so the second most common answer would, or the second most popular answer was at 27% people thought that stridor and distress would constitute a reason enough to do 5 back blows and 5 chest thrusts. However, we would say that if the child is still moving air, and you know that they're moving air because they still have stridor, that they're still trying to work that foreign body up themselves, and so we would allow them to continue to do that until the airway is completely occluded, at which point in time you would attempt to do the 5 back blows and the 5 chest thrusts. So moving on, we will talk just a little bit more about the foreign body management. So as we've already alluded to, at this point in time, if the child is still moving air, you actually don't need any intervention. You can give them supplementary oxygen if they need it. However, you want to do this in the least invasive way possible. You don't want to agitate this child anymore. You don't want to move the foreign body into a place where it's actually completely obstructing the airway, and so you would want to provide the oxygen in a way that's not going to distress the child more. Often children don't respond very well to putting a face mask on, so sometimes blow-by is really the best way to go, and have the parent hold it and allow the child to remain in the position of comfort. So if they're sitting up, it's because they're protecting their airway and they don't want to be forced into a position that may cause them to have more respiratory distress. So we would recommend allowing them to remain in the position that they're most comfortable. So then the scenario progresses and the child's stridor acutely resolves. The child is trying to cry, but there's no audible noise heard and does not appear to be moving air. So then our management, as we've said as per the last poll question, would be the 5 back blows and the 5 chest thrusts. And you would continue to try those until the child loses consciousness. So once the child loses consciousness, then you would need to think about what is the next step in your management at that point in time. And so you may attempt to look in the child's mouth with a laryngoscope. You may try to remove the foreign body if it's visible with a set of McGill's. And then you need to prepare for cardiac arrest and CPR and think about further airway management depending on what your skill set is. And then you need to get that child as quickly as possible to definitive care.
And in terms of the laryngoscope and McGill's, that would be reserved for our ACP paramedics. Oftentimes when you do these back blows and chest thrusts, you may dislodge that foreign body. You may, when it wasn't present in the upper airway, it may be present in the upper airway at that point. So maybe a good time to recheck that upper airway, maybe even in their mouth at that time where it can be removed.
Okay, great. So just some key points then on foreign body aspiration. It is one of the leading causes of death in infants and young children. Most cases occur during the 1 to 2 year sort of age range. The most common thing that children aspirate is food, with the most common food item really being peanuts. The presentation is very variable because it can be an upper airway obstruction, but it can also be a lower airway obstruction. So you may hear stridor if it's upper airway, but you may hear other respiratory noises such as wheeze if it is a lower airway aspiration. So you really need to have a high index of suspicion if there is a history of acute onset of coughing, because often the aspiration is actually not witnessed, and so you will not get that classic history where the parent says that they saw them eat a grape and then they started choking. Often it's just that they were eating lunch and they started choking, or they may have just been like playing with toys and they started having this acute episode of coughing and then have been coughing ever since. That's a very common history that we get in the pediatric emergency department. So you do have to have a high index of suspicion so as not to miss this diagnosis. Okay, so we're moving on to case number 2 now. This is a 3-year-old male whose home you're called to at 2 o'clock in the morning. He's had a history of rhinorrhea for 1 day, and his parents woke up from sleep because he was having really noisy breathing. And so we'll see if I'm able to get this working. I may just try and play it from my computer here. No, so it doesn't seem to want to cooperate with us today. Okay, so did you find one? No, that's okay. So this baby is, or this, sorry, 3-year-old is experiencing stridor. So it's again that upper airway noise, but now also has that really classic barking cough. Okay, so we'll see if we can get a video. Matt's gonna try and look for one for us. So what is the most likely diagnosis when you hear that this child has stridor? So it's that inspiratory upper airway noise along with the barking cough. So you should be thinking about what your differential diagnosis is along with what the most likely diagnosis is. So this is in fact croup, so very common that you see this. And so your indications in terms of treatment of croup would be if the child is in severe respiratory distress, if they've got stridor at rest, if they've got a current history of an upper respiratory tract infection, if they currently have a barking cough, or if they have a recent history of a barking cough. They have to be under the age of 8 years, and their heart rate has to be less than 200 beats per minute. And in those children, it would be appropriate for you to consider treatment with a neb of epinephrine. And so the dose is based on both their age and really based on their weight. And so you've got that directive to go ahead and give them the neb of epinephrine to try and settle their respiratory distress should they meet all of those criteria that we've just reviewed. And then of course you're always supplying supplementary oxygen if needed. And again, just keeping in mind that you're allowing them to be in the position of comfort and allowing the parent to administer the oxygen in the most comfortable way for the child. So just so you know what our management would be in the emergency department, we would continue the nebs of epi if needed, and we would prescribe them an oral steroid. And it's actually not a prescription because we just give them a one-time dose of dexamethasone within the emergency department. Every now and then they'll be prescribed 2 doses, so they would get 1 in the emergency department and 1 for home. But for the most part, we give them 1 dose of dexamethasone, which is a long-acting steroid, which will provide them relief for the next couple of days. And most of the time they're discharged home because they don't have any reason to be admitted to hospital. They very rarely would have an oxygen requirement. The croupers sometimes do have a fever. About 50% of them would have a fever. And actually that leads me to my next slide. So just some key points. They classically have the triad of barky cough, stridor, and a hoarse voice. As I said, about 50% have fever. This is also known as laryngotracheobronchitis, and that tells you it's just you know, highlighting the anatomic structures that are involved in croup. It is a very common upper airway obstruction in children, something that I'm sure most of you have seen pretty frequently. The etiology is viral, so there is one virus in particular that tends to cause croup, which is parainfluenza, but there are multiple other viruses that can do this. And just keep in mind that they have stridor, okay, so it's that inspiratory noise. They can have biphasic stridor when it's really severe, which means that they've got you know, a noise both with inhalation and with exhalation, but it is an upper airway noise. So put your stethoscope over their neck and confirm for yourself that it is primarily upper airway and that it's not actually in the lower airways, and that maybe what you're hearing in lower airways is just a transmitted upper airway noise. And so we do see this anywhere between 6 months and 6 years. Sometimes we do see it in older children as well, especially if they've got a history of having had croup in the past. We do see it in the older years, but primarily it's between 6 months and 6 years.
So I've got a little sound clip here. We heard earlier some stridor. So this is kind of the, for those who haven't heard it, the barky cough that you may hear with croups. Something along that line, as well with the inspiratory high-pitched noises, stridor.
That's great, thank you. Okay, so we're going on to case number 3 now. So this is a 2-month-old male whose home you're called to at 2300. He's had a cold for the last 2 days and had an episode where he seemed to stop breathing and turn blue. The parents tell you that the entire episode lasted for less than a minute and that the parents did CPR on the child, including both breaths and chest compressions for about 30 seconds. And so this is another video. We'll see if Matt can find something for us here. Okay, here we go. That's great. Thanks, Matt. Okay, so try and think about what it is you thought you heard just now, because that should really help you with creating a differential diagnosis. So what do you think is the most likely diagnosis given the history that you've heard and now given that audible noise that you just heard? And then also, what are some other differential diagnoses? And so hopefully you're thinking about bronchiolitis. So what you heard was wheeze. Okay, so that's an expiratory noise that is in the lower airways. And so we'll talk about the management of bronchiolitis. So you do provide supplementary oxygen if needed, allow for the position of comfort, and then as per your EMS directive for bronchoconstriction, you can do Ventolin. So it is dependent on their weight, so you can give them anywhere between 6 and 8 puffs via MDI or 2.5 to 5 milligrams via nebulizer. And if the child is not in severe respiratory distress, there really isn't any difference between giving them the MDI versus the neb, but if they're in severe respiratory distress, they're having a lot of difficulty, you'd be best suited to just go ahead and give them the neb. With all of that being said, there's no evidence for giving Ventolin in the bronchiolytic. Okay, so the only evidence is really for supportive care, which means that providing them with oxygen and providing them with hydration if they're having such severe respiratory distress that they're unable to stay hydrated would be really the only management. Ventolin's not likely to be effective because the pathophysiology of bronchiolitis is airway obstruction. It's not airway constriction as it is in an asthmatic. And so also we know that young children, so babies, that they don't have the receptors that Ventolin acts on in the airways, and so it's highly unlikely to be effective, but it wouldn't be harmful if you felt that you wanted to try it for somebody who, for a young child that seemed to meet the bronchoconstriction directive. So in the emergency department, we do the supportive measures. This would also include nasal saline with suction because, again, often these bronchiolytics are less than 4 months of age and they are, again, obligate nasal breathers. And so sometimes just sucking out their nares is very helpful. In the severe bronchiolytics, we would also try a neb of epinephrine. So just some key points. It is a common cause of lower airway obstruction in infants. Again, the etiology is viral, primarily RSV or respiratory syncytial virus. Those that are at higher risk would be the premature infants, those with chronic lung disease or congenital heart disease. Most often they do present with respiratory prodrome, meaning that they've got a bit of a cough, maybe some rhinorrhea. They often do have an audible wheeze, but sometimes it is only heard with the use of your stethoscope. Apnea is very common in this high-risk group, so you need to be very cognizant of looking for that because, again, if you have a bronchiolitic that's having apneic spells, which was the case in this scenario, they're at very high risk for impending respiratory failure, and so they need to get to definitive care quickly. They have increased work of breathing, they're tachypnic. They often do get very dehydrated because they're breathing so quickly. Often these bronchiolitics are breathing at rates of 70 or 80 per minute, and so they are not able to coordinate a second swallow, and so that's why they get so dehydrated. They also very frequently have hypoxia. So that's another big difference between the Croupers and the bronchiolitics. The Croupers very rarely have an oxygen requirement, whereas the bronchiolitics often have an oxygen requirement. And that really has to do with the pathophysiology of the illness. So because bronchiolitis is a lower airway illness, they do have ventilation perfusion mismatch, which means that they're not able to oxygenate their blood as well as what they would be if they didn't have this illness that's causing them to have, some lung collapse and some alveolar collapse, as well as a significant inflammation in the lower airways. Okay, so now we're going on to case number 4. So this is a 6-year-old, and you're called to her school just after lunch, so at about 12:30. She's sitting in the principal's office, and she seems to be leaning forward with her hands sort of braced on her knees. She does make eye contact with you, but is only able to speak one word at a time. She's got increased work of breathing, so she's got some supraclavicular indrawing, some nasal flaring. She does not appear cyanotic, and your general impression of her is that she's unwell. So then you go on to formally assess your ABCs. So you determine that her airway is patent, that she is breathing quickly at a respiratory rate of 40. She's got decreased air entry into her bases bilaterally, and she's only satting 92% on room air. In terms of her circulation, she's got good capillary refill, but is quite tachycardic at 150, and she seems to be alert and appropriate. So then you get a little bit of history. Her principal says that during lunch she started complaining about an upset stomach, she vomited twice, and then she started having some trouble breathing, and that she forgot her blue puffer at home today. So just with that little piece of information, you start creating your differential diagnosis. So what things could be going on with this child? So I just want you to think about those things in your head, and what do you think is the most likely diagnosis at this point in time? So now she tells you that she also had a watery stool and that her throat feels itchy. So that piece of information should help a lot to help you delineate what your most likely diagnosis is. So initially, when she just tells you that she had an upset stomach, she vomited, she's having some trouble breathing now, there's some evidence that she's most likely an asthmatic with the blue puffer. So could this just be an asthma exacerbation? Yes, it could be. Could it be that she's just got a really bad gastroenteritis and maybe she's like had some aspiration and now she's having difficulty breathing? That would also be on your differential. But now that she tells you she's having a watery stool and her throat's feeling very itchy, you should really be thinking about anaphylaxis.
So we're ready for our next poll question here. We're just going to share that in a second.
Okay, so you should see the third poll up there now. And now we're asking what is true regarding anaphylaxis. All right, so we'll go ahead and close that poll, show you the results.
Okay, so we've got people thinking a wide variety of answers may be true. So 32% of you think that 50% have skin or mucosal membrane manifestations. And in actual fact, it's actually much higher than that. So about 80 to 90% of anaphylaxis has skin or mucosal membrane involvement. 11% of you believe that epinephrine is frequently given unnecessarily by parents. It's actually the opposite. Parents are very hesitant to give epinephrine, and so we need to provide better education to parents about the recognition of anaphylaxis, as well as the time sensitivity in administration of anaphylaxis, and that really epinephrine is the only life-saving measure that we have for anaphylaxis. And so really we're encouraging parents to err on the side of giving the EpiPen if they have any concern about their child that this could potentially be an anaphylactic reaction. We're really encouraging them to give it sooner rather than later, and not to wait until they get to the emergency department for administration. And then 46% thought that the pediatric auto-injector is used for patients less than 10 kilos. Actually, the pediatric auto-injector is for children 10 to 25 kilograms. So there isn't any auto-injector if the child weighs less than 10 kilograms. So the true answer is the hypotension. So if the child has a history of a known allergy, so let's say the child is known to have a peanut allergy and you're called to see them and you find that they're hypotensive, that's enough to define anaphylaxis. And we will go over the formal definition of anaphylaxis because there is often a lot of confusion about what the definition of anaphylaxis is and what criteria you need to meet in order to administer epinephrine.
And just going back to your point about the PEDS auto-injector, so that's actually a patch point. So if the patient weighs less than 10 kilograms, that would be an indication to patch into the base hospital physician to discuss treatments at that time. I was also very interested, we were talking before we started this presentation about the actual lack of recognition of anaphylaxis amongst caregivers and parents, and the hesitancy to give epinephrine. And I know a couple of years ago we had a big push because we were seeing this in the adult patient population with kind of our QA and QI, was that anaphylaxis was being under-recognized in the adult patient population. But anecdotally, we were talking beforehand, and Sheena kind of informed me that you noticed that even with patients coming in by parents alone, that they have the EpiPen, they know how to give it, but they often are reluctant to do so. So kind of just broadly, globally, it's maybe under-recognized.
Yeah, definitely. Thanks for echoing that, Matt. So here on our next slide, here's your management for anaphylaxis. So your indications are that there has to be an exposure to a probable allergen and that they need signs or symptoms of moderate to severe allergic reaction. And so it's my understanding that you would be drawing up the epinephrine yourself and that you would be giving a weight-based dose. So it's 0.01 milligrams per kilo up to a max dose of 0.5 milligrams that you would be administering of epinephrine 1 in 1,000 concentration via IM injection. And so of course you would also be giving oxygen if needed. The second thing that you can do for the children in whom you're concerned about anaphylaxis would be to administer diphenhydramine or Benadryl. And so this again is a weight-based dose, and you can either give it IV or IM. So if they're between 25 and 50 kilograms, you would be giving them 25 milligrams, and if they're over 50 kilograms, you would be giving them a 50 milligram dose. And then, the third thing that you could do is if they did also meet criteria for bronchoconstriction, so you were concerned that they were having difficulties breathing and that they were wheezy, then you could also use your salbutamol directive. And so in the emergency department, we would continue much of the management that you would have already started. So we would repeat the IM epinephrine if needed, or we would give it if it had not already been given. We would give them Benadryl if it wasn't already given. We would give them steroids, either IV or orally. Those steroids would often be continued after they are disposition from the emergency department. So if they do in fact go home, oftentimes providers would give them a course of steroids for home. We often do give ranitidine even though there isn't really good evidence for it. And then observation is really a key part of our management for these potential anaphylaxis children. So if epinephrine is administered, we would be watching them in our department for at least 4 hours because we would be concerned that they might have a rebound anaphylaxis. So now just to highlight some key points about the definition. So I'm going to give you 3 different scenarios. All 3 of these scenarios would meet criteria for anaphylaxis. So let's say that you've got a child that, maybe is just playing outside, wasn't known to eat anything, but all of a sudden they've got acute onset of illness. So they've got, let's say, hives, so they've got some skin involvement, and all of a sudden they start having really severe wheezing and are having difficulty breathing. Even though there isn't any known exposure to anything, they would meet definition. By definition, they would meet criteria for anaphylaxis because they've got acute onset of both mucosal membrane or skin involvement along with respiratory involvement. So that's scenario number 1. They would also meet criteria if they had low blood pressure in this scenario. Low blood pressure could also result in, a syncopal episode, and that would constitute anaphylaxis as well. So that's just getting a little bit complicated, but I think the bottom line really is if you've got skin involvement along with respiratory compromise, even if they don't have a known trigger or exposure, that's still anaphylaxis. The second scenario would be that the patient has a likely exposure to an allergen. So let's say they were out playing in a park and they got stung by a bee, or they were at a picnic and they were eating, peanut butter, or they had something with nuts in it, or even if the food item wasn't known but they were known to be eating, that would be enough. So they just need to have 2 systems involved in that scenario. So it can be skin, it can be respiratory, it can be blood pressure, and it can be gastrointestinal. So we do see gastrointestinal pretty frequently in pediatrics, primarily with upset stomach, so they're complaining about abdominal pain, and then they may or may not also have vomiting with that. So any 2 of those with likely exposure constitutes anaphylaxis. And then the last one, which is tricky, which is very, very infrequently seen, would just be a reduced blood pressure. So they're hypotensive, but they're known to have an allergy to something. So this is your child that's allergic to peanuts, that accidentally ate a granola bar that has peanuts in it, and somebody's concerned, they call you, or you're assessing this child with possible anaphylaxis, and you note that they're hypotensive and that they've ingested something that they're known to be allergic to. This is anaphylaxis, and they should be administered epinephrine at some point in time, sooner rather than later, because as we mentioned earlier, administration of epinephrine is very time sensitive, and it is the only management we have that actually saves lives. So just to wrap up some other key points, so cutaneous manifestations, as we said, are very common. 80 to 90% of children would experience these. The signs and symptoms are very variable. Only 30% actually have an identifiable trigger, which can make this a difficult diagnosis to make. Food is by far the most common trigger, followed by insect stings. And so, as I mentioned earlier, we are really pushing for healthcare providers as well as parents to err on the side of giving the epinephrine, because we do see that children are frequently undertreated for anaphylaxis. Okay, going on to case number 5. This is the case of a 12-year-old male whose house you're called to at 1900. You find him lying on the couch with his eyes closed. He doesn't have any abnormal audible noises, but he does appear tachypnic without any obvious increased effort. His circulation appears normal. So your general impression of this child is that he's unwell, that there's definitely something going on with him. Your formal assessment of ABCs reveal that his airway is patent. He's breathing at a rate of 34, so he is tachypnic for his age. He's got good air entry bilaterally. He's satting well on room air at 98%. He's tachycardic at 140 with a normal capillary refill, and his GCS is a little bit low, so he's slightly difficult to rouse, and so you give him a GCS of 13. I can't remember where the next. Okay, so the history that you receive is that he's been unwell for the last 3 days with cough, rhinorrhea, and fever. So start thinking about what you think could be going on with this child. What's the most likely diagnosis, and what are some other differential diagnoses that you would put on the list for this child? So initially it may be a little bit unclear. So what that means is that you would need to keep a broad differential diagnosis. So could he have pneumonia? Yeah, it's possible that he could have pneumonia. Could he just have a viral infection? That's also possible. But then you're given a little bit more history. So he started to have some abdominal pain and he's been vomiting today. So now your differential diagnosis broadens. So could he have like a gastroenteritis? Could he be a surgical abdomen? Could he have a UTI? All of these things would be on your differential. But now the mother says that he's been urinating more frequently for the last week and that he's lost weight over the last 2 weeks. So for some of you, this may start to ring off some sort of bells and whistles as to what could be going on. So this is a very classic history for the diagnosis of diabetic ketoacidosis. And so one thing that I really want to point out in the initial physical presentation, so the fact that he had quiet tachypnea should really tip you off to the fact that something other than maybe a respiratory cause might be going on. So quiet tachypnea is really a key that maybe it's not the respiratory system, maybe it's one of the other systems that's causing the child to be tachypnic. And so for your management for the DKA child, it's really all supportive things. So you're assisting them with the airway, giving them oxygen if needed, you're providing them with some IV fluids, and then you can also do a glucose check, which won't change your management for the child. The glucose check will reveal a very elevated glucose, but it will just help to add to the picture to confirm that that DKA is really a high possibility for the child.
So again, for IV fluids, definitely if they're hypotensive, then that's an indication to give the IV fluids. If they're showing all signs of DKA and it's, you have quite a long transport time, then it could be reasonable to give a BHP patch at that time for fluid orders. Most of the times you're close to a center, again, 10 minutes of fluids probably won't make much of a difference in these patients, more for the long transports. And of course, with the pediatric patients, then it's also a patch point for IV fluids as well.
Okay, great. And then also in the emergency department, we would continue with IV fluid rehydration. We would start an insulin infusion for these children. They've got really frequent monitoring that needs to be done, so both for their vital signs as well as for their neuro status, frequent blood work, and these children would all be admitted to hospital. So some key points about DKA. It is an acute life-threatening complication of type 1 diabetes. About 25 to 40% of children with type 1 diabetes do present in DKA initially. So many of them will not have this history of having had type 1 diabetes because this is their initial presentation. So many of you will end up transporting these children into hospital. Just very, very briefly on the pathophysiology of DKA, just out of interest's sake, it's more complicated than this, but insulin levels are very low, glucose levels are very high, and so because insulin levels are low and the cells can't uptake the glucose for that reason, fat is broken down for energy, and the fat, one of the byproducts are ketone bodies, and the ketone bodies, along with a number of other mechanisms, cause severe acidosis in these children, which causes them to experience this quiet tachypnea that was described in this scenario. So again, quiet tachypnea should tip you off to the fact that maybe something other than a primary respiratory etiology is going on. They're also very frequently dehydrated, and again, a number of mechanisms play into this, but they often have abdominal pain with nausea and vomiting that contributes to the dehydration. They've also got polyuria, polydipsia, weight loss, and very low energy levels. So it's all of these things on history that would help you to think about this diagnosis. Okay, so we've got 2 cases left. Moving on to case number 6. This is a 5-year-old male whose home you're called to at 3 o'clock in the morning. You find the child curled up in Dad's arms. He seems to stare right through you. He doesn't want to answer any of Dad's questions. He doesn't have any audible noises, but he does appear to be working really hard to breathe. He's got nasal flaring, tracheal tugging, retractions. He does not appear cyanosed, and your general impression just at first glance is that this child is very unwell. You determine that his airway is patent, that his respiratory rate is elevated at 48, that he's got decreased air entry bilaterally, and that he's not satting well at all on room air, only satting 88%. He's tachycardic at 168 beats per minute, and he's got a good cap refill at 2 seconds. And then you give him a GCS of 14 just because he seems, you know, to be maybe a little bit confused with staring right through you and not wanting to sort of answer questions. One more slide. Okay. So then you are also told that he's got a history of asthma, that he's been taking 2 puffs of Ventolin every 2 hours for the last 8 hours, that he's had some rhinorrhea and a bit of a cough for the last 4 days, he's been afebrile, and that Dad says the Ventolin really hasn't been seeming to help him. So start thinking about what you think the most likely diagnosis is, and then what could be some other things that are potentially going on with this child. So what would be your management at this point in time?
So we're just going to have our next poll question here.
All right, so we're asking what the most likely diagnosis is for this child in case 6.
And you know what, while you're answering this, I'm going to go ahead and tell you that you attempted to give him a neb of a neb of Ventolin. You give him a neb of Ventolin and there isn't any change at all. So think about that when you're thinking about what the most likely diagnosis is for this child.
All right, so we'll go ahead and close that and we'll show you the results.
Okay, so very good. I agree that the most likely thing is that he is having an asthma exacerbation secondary to a viral etiology. Viral triggers are very, very common in asthma. It is definitely possible that he could be having a pneumonia as well. Myocarditis is a very rare diagnosis, something definitely to think about in the very, very unwell looking child. And bilateral pleural effusions, yes, that could be a complication of a very severe pneumonia. Most likely those children would be febrile. So I wasn't trying to throw you off, but I was trying to give you a scenario that we do often see where children require a fair bit of Ventolin to really assist them in getting over the hump with a really severe asthma exacerbation. So as I said, you give oxygen, you give a Ventolin neb, and there's no improvement. So what you should do after that is probably administer more Ventolin. So the key point being that often children with severe asthma exacerbations don't wheeze because they're so tight, and so you need to administer Ventolin quite liberally to try and open them up. So after you give a second neb of Ventolin, the child begins to wheeze and is able to speak in one-word sentences. So we've gone over this, supplying oxygen, allowing them the position of comfort, and then your bronchoconstriction directive. And then in the pediatric emergency department, we would continue to do the Ventolin. We often also give Atrovent, so it's an anticholinergic agent which can help to dry up any secretions, and it does work synergistically with Ventolin. We would give them steroids, so either oral or IV, depending on their work of breathing. We would also consider giving them magnesium sulfate, which is a bronchodilator via IV. And then if they're really severe and not responding to the above management, then we would consider doing either a Ventolin infusion or, in fact, an epinephrine infusion. So just some key points about asthma. It is a common, potentially life-threatening disease. It is the leading cause of admission to hospital in children. Oxygen saturations in children less than 97% are abnormal unless they've got some underlying condition that causes them to have a low resting SpO2. So just something to think about. Not all that wheezes is asthma, and severe asthma often doesn't wheeze. So think about being liberal with Ventolin in the kid that's got a really classic history of really bad asthma exacerbations, because it often does take a fair bit of Ventolin before things start to improve. So case 6 goes on. You're en route to hospital. You've got her in the ambulance, and all of a sudden her oxygen saturation drops down to 78%, and it seems to be continuing to drop. So what is your initial management? You should start by reassessing your ABCs. So you should be looking at her airway. You see that her trachea is deviated to the right, and that she's got absent air entry down into the left lung fields. You quickly check her heart rate, and it's 70 and seems to be decreasing, and her blood pressure is low, so she's hypotensive at 70/38. So think about what you think is going on with this child acutely. In a child that's got a very severe asthma exacerbation, she would be at risk for this. And think about what you would be doing. So for the PCP providers, you would continue your supportive care and your rapid transport. But for an ACP provider, this child does require emergent needle decompression because she is experiencing a tension pneumothorax. And so what you would do is elevate the head of the bed to 30 degrees, try and identify the second intercostal space, mid-clavicular line. You would attach a 14 gauge angiopath to a large syringe, and you would start to insert the needle perpendicular to the chest, just superior to the third rib, and you would want to be aspirating on the syringe as you advance the needle forward. And once you start getting air back, you continue to once you start getting air back, you continue to try and withdraw as much air as you can, and you continue to do that until no more air is coming back. And you continue to monitor for clinical improvement, and of course continue your rapid transport. So this would be a rare scenario, but this would be the scenario or the type of child that would be at higher risk of developing a tension pneumothorax, a child that has a very severe asthma exacerbation. Okay, this is our last case. This is a 1-week-old male whose house you're called to at 7 o'clock in the morning. They appear flaccid in the mom's arms with no spontaneous movement, not crying at all, appears very tachypnic with no signs of increased work of breathing. So again, this is the quiet tachypnea that we talked about earlier. Appears very mottled and gray, and your general impression is that this child is very unwell. You assess airway, breathing, and circulation. So airway is patent, breathing at a rate of 60, so is just bordering that tachypnea sort of line for an infant, has good air entry bilaterally, but is only setting 80% on room air. Circulation, capillary refill is 3 seconds centrally, heart rate of 170 with a GCS of 12. So you're very worried about this infant. So in terms of history, the baby was born at home by a midwife, and the parents say that maybe the baby's appeared a little bit bluish over the last couple of days, but has been very sleepy, difficult to feed in the last 48 hours. So you need to think about what's going on with this baby, what do you think the most likely diagnosis is, but what could be some other etiologies going on with this baby as well. So your differential diagnosis should really include things that cause a baby to be cyanotic, along with some quiet tachypnea. So the differential diagnosis is very, very broad for this infant. But regardless of that, what would be your management priorities given that this child is setting 80% on room air? So what you do is you put some oxygen on this baby right away, and you notice that the SpO2 really doesn't budge. So it was 80 and now has maybe gone up to 81 or 82 with a little bit of oxygen. So that should help to narrow down the differential, and if maybe you're not aware of it right now, you will be by the end of this presentation as to what you should be thinking about in the child that, especially in the infant, that you provide oxygen to with no SpO2 response. So initially, before you apply that oxygen, your differential diagnosis should be very broad, so you should be thinking about sepsis in the infant that is cyanotic. They could have a pneumonia, they may have pneumothoraces, they could have congenital heart disease, they could have diaphragmatic hernia, which is when the bowels herniate up and start to compress the lungs. Many rare causes. Also, you would be thinking about like neurologic causes. So if they had a low respiratory rate and are cyanotic, you would be thinking about like a head injury or apnea of prematurity or some other very rare things. But again, the point is that the differential diagnosis for the cyanotic newborn is very, very broad. But once you've applied oxygen to the infant and you see that the SpO2 is not budged at all, that really helps to narrow the differential, or it helps to at least move something up to the top of your differential, which would be congenital heart disease. So key things here are that you need to provide oxygen and support the airway and get to the hospital quickly. So our in-hospital management would be initiation of a medication called prostaglandin, which is potentially life-saving. What it does is it helps to keep the PDA, or the ductus arteriosus, open. And we would do an emergent echocardiogram and get cardiology involved right away to figure out what the plumbing problem is or what the heart problem is with this child. So just some key points on congenital heart disease. So red flags on history. These children are often have a lot of difficulty with feeding. They're very lethargic. They've got poor weight gain. And I put home birth on this list of red flags just because now in hospital we are doing something called pre and post ductal saturations, which just means that the child has an oxygen saturation done both in the right and the left hand, and oftentimes that can pick up a number of children with congenital heart disease. It definitely doesn't pick them all up, so there will still be children born in hospital that slip through the cracks that are found to have congenital heart disease, you know, in the first couple of weeks of life usually. But home birth is a risk because this most likely would not be done. Some red flags on exam are true cyanosis. So what I mean by that is the picture sort of in the middle here, or more to the left, that baby is truly cyanotic. So the entire torso and the face are all cyanosed. Whereas the baby to the right, you can see that just the hands and the feet appear to be cyanotic, and that's called acrocyanosis. And this is a normal finding in infants, usually those that are younger, like within the first month, but it can even be normal up to 2 months of age to see this acrocyanosis, and this is just a normal physiologic response to being a little bit cold. The other big red flag on exam is quiet tachypnea. So again, just like with the other case, quiet tachypnea should make you think that maybe something other than a respiratory issue is going on. If you were to listen and you heard a loud murmur, if they had absent femoral pulses, they've got a low oxygen saturation that's not increasing with oxygen. If you were for some reason to put the SAT monitor on one hand and then on the other hand, and you see that there's a big difference between the two, by a big difference I mean greater than a 5% difference, all of these things would tip you off to think about maybe this child has a congenital heart problem. And so really it just means that you need to get to the hospital faster and that you would continue to support them with oxygen and support their airway however you best can. So that concludes our cases. So these are just some overall take-home points that I wanted to review. So as Matt said earlier, children are not in fact small adults. There are significant differences in their airway, both in terms of anatomy and physiology, and this is what results in the different pathology that we see in children. The diagnosis is usually in the history, so do your best with trying to get some key points out of parents. Stridor is a high-pitched inspiratory noise indicating that there is upper airway obstruction. And one point that I meant to mention earlier with regards to stridor, the reason why we see stridor in children and we don't really see the stridor in adults as much is just that because their upper airway is so much smaller, a little bit of inflammation goes a long way in children. So meaning that if you've got 1 millimeter of inflammation in a child, that can mean that, you know, a large portion of their airway, even up to like 70 or 80% of their airway is stenosed, as compared to an adult where 1 millimeter of inflammation may only mean that a very small amount of their airway is stenosed. And so that's why we frequently will see stridor in the younger children, and that's why Croup is an etiology of younger children, and we don't see it in teenagers. Wheeze is classically an expiratory sound indicating a lower airway obstruction, and so it's really important to do your best to try and differentiate between stridor and wheeze. Provide oxygen in the best way tolerated. Allow the child to remain in the position of comfort, and try and keep a broad differential diagnosis with respiratory distress, because every now and then the primary cause will not in fact be respiratory in nature. And so that concludes my presentation, but I'm happy to answer any questions, and Matt's also here to answer any questions that I'm unable to address.
Thank you very much, Sheena. I'd also add on to that take-home point there, the other point you brought up too with anaphylaxis is the under-recognition of anaphylaxis. So just remember, two or more systems involved and then treat as anaphylaxis. Even parents are maybe under-recognizing it as well. So we've had to push on for that aggressive treatment of anaphylaxis. And the other one too, again, which we kind of hammered home in our annual CME day this past year, is that not all respiratory issues are related to the lungs alone. So think outside the lungs as well, for the heart, metabolic causes as well. Sepsis can also cause tachypnea and some respiratory distress, so keeping that differential very large. We've had a couple questions come in throughout the presentation. The first one, if the patient is greater than 12 years of age and we're thinking of DKA, should we still patch, and what would a common IV infusion volume be? So again, this is the clinical judgment of the paramedic. So short transport times, if you're just 5 minutes away from the hospital, again, the IV infusion of 100 milliliters of fluid in this patient probably will not make the world of difference. If you have a longer transport time, then definitely if they're showing signs of DKA and volume loss and they're not hypotensive, then that would be an indication to patch. So we're going to give you the clinical judgment, realizing that a lot of the times they won't get a lot of volume pre-hospitally. And then again, children less than 12 years of age and DKA, that is a mandatory patch point for IV fluids. The second question regarding foreign body airway obstruction and regarding the kind of management of that. And the question coming in relates to the AHA guidelines about children less than 1 year of age. Should they have 5 back blows and 5 chest compressions regardless of being fully obstructed or partially obstructed? So I guess this is, again, comes down to clinical judgment. In the case we gave here, the patient had kind of had this stridor for a few hours. So yeah, had some stridor involved, but was not in super amount of distress, was not hypoxic. So again, weighing the stress of going at someone with chest thrusts and back blows and that causing more airway distress than just leaving them be and supporting them to the hospital. There's going to be times when, yes, you get there and they're in severe distress and they have stridor even silent, then again, that's when we want to move to the 5 back blows and 5 chest compressions. So again, it's going to be when your clinical judgment comes into play, the degree of distress that they are having before going down that route. So I just want to thank Sheena for this great presentation. I think you covered a lot of information in a short period of time and very, very high yield topic here, respiratory distress in pediatrics. Again, it's a low frequency, high stress patient population that we do encounter both in the emergency departments and in the pre-hospital world. So thank you very much, Sheena, for lending your expertise today and doing a great job of going over this presentation on respiratory distress in our pediatric patient population.
All right, thank you very much. I hope it was helpful.
I'd just like to echo again a thank you to Sheena and Matt, and also share with the audience just a quick update on some of the other educational opportunities that we have coming up. So do have a look at our website, lhsc.on.ca/BHP, and check out our brand new events calendar. We have an ECLS course coming up on March 22nd and 24th. As well, we have a couple 12-week courses in March. We've got 2 in March, 1 in London, 1 in Walkerton. Another 12-week course scheduled in May in London as well, and a number of other opportunities coming up with webinars and things that are online. So please do have a look at that. And again, thank you to Matt and Sheena. Have yourselves a great day.